you to kindly answer for us the key question that I don't think has been adequately answered or people have adequately grasped. Why move to SHA, a whole new body, yet we had an NHIF which you could have reformed. So why this shift? Was it really necessary? And don't you feel that it was rushed and not everyone really got to give the opinion? Like the court said, the public participation was questionable. So why that shift and why now? Dr. Mwai.
Thank you very much, Dr. Khalil, and good evening, everyone. If allowed, I could share my screen.
Why, if you're speaking, we cannot hear you.
Hello? Hello?
Oh, okay, good. You're good, go ahead.
Yes, I was saying if you could allow, I could share my screen. Thank you very much. So I wish to take some few minutes just to lay ground for our discussion today, and more importantly, to just highlight the origin of this health reform. And I'm pulling this ideally from, previous discussions that we have had. And we ask ourselves then, what ails our healthcare system? And we began by interrogating as professions, what is the main issue that we have within our healthcare system? The first component we saw is that the reason why patients don't actually come to our facilities is because of lack of commodities, and therefore commodity security became one of the key pillars which we believe need to be anchored within this reform. The second thing was the integrated health information technology, because we realized that the healthcare is actually disjointed. There is no place where the public speaks with the private, the supplier speaks with the dispensing facilities, the body in charge of quality of commodities has no clear horizon on what is happening within the market. And therefore, that's where the integrated issue became important, integrating the whole of the healthcare system through technology. And then of key importance, of course, for this meeting also is the fact that the human resource we have for health are largely inadequate. There are great, attempts within the past to actually, build better and more human resource for health, employ more doctors, more nurses, more clinic officers, but these have actually fallen, sometimes into years that ideally have not taken in consideration to this, more so after the devolution of the human resource for health. And the last one, of course, is healthcare financing. So when we discuss this, then it is important to note that the healthcare financing discussion cannot be held in silo, ignoring the other three critical components. And therefore, the three of them are critical. And of course, the financing provides the inputs that are necessary for the same. Just to highlight then what was the problem, I want to highlight one, the issue of the increasing burden of disease, which this team in this meeting knows far much better. But of great importance is the increase in the incidences of non-communicable diseases. More importantly, the cost of treating these non-communicable diseases, which partly push households into incurring catastrophic spending, but also, pushes household into poverty, is what we call impoverishment. Now, we were working within an NHIF that had a lot of fragmentation. That means that it is an insurer which had pulled some other small grouping inside a pool, and therefore it was not absorbing the loss of insurance, which is pooling of risk. So an insurance should be able to pool risk, should be able to randomize that risk, identify the person who have paid. That means that when you pay, you should be able to receive services, and then you do strategic purchasing of healthcare services. We had also poor distribution of healthcare providers. And this is because majority of the providers who the previous NHIF was paying for were actually largely urban, where private sector was well, connected, and also with less regard to payments of lower level facilities, that is level 2 and 3. And this needed to be corrected because with lack of payment in level 2 and 3, it used to propel the household to go and seek services in higher level facilities. The other important thing that we need to highlight was the fact that with the overemphasis on paying for healthcare in higher level facilities, then prevention, primary healthcare facilities were left, without any funding. And after devolution, we lost the autonomy of some of these facilities, more so 2 and 3, to be able to have some pool of resources that they can use to better, their services, and also give the medical officer in charge of the facility some autonomy to have resources to be able to use to improve his facility, or even hire for some resources that could not be available within the facility, or even pay for locum within government facilities where there is a big line, less human resource, but there is no motivation because the facility will generally get the money and then deposit the money for the county. The facility is left without resources. So it demotivates the workers within the public facilities, for instance. And therefore, the other important thing that was highlighted is, of course, the issue of public facilities not really being the main providers of service, because you could see that services in Kenya is almost split half-half between public and private. Therefore, any healthcare financing reform should actually target to have both the public, private, and faith-based, so that we take into consideration and empower the person who is seeking services, and so that they can seek services where they are available. Of essence, to highlight is the lack of financial sustainability. And this is where a lot of funds that were landing within NHIF were spending above 100%. For instance, the schemes that are managed were, spending at 140%, 170%, 271%, and this is financially, impossible to actually deal with this. Another important thing was the fact that there is huge poverty in Kenya, and the government should be able to target and put in money to make sure that all Kenyans, get services within the system. The low participation of the formal sector because of lack of, informal sector, because of lack of ability to enforce contributions for the same within the informal sector was a key problem that made the formal sector to carry the whole burden of financing healthcare in Kenya, which is impossible because they are already 20% compared to the 80% who are non-informal in Kenya. Therefore, the system needs to be architectured to focus on the informal sector. I have needless to mention the issue of catastrophic spending that I have mentioned, and impoverishment, and more importantly, poor payment of healthcare workers at facility level and dependency of the medical workers to a hospital system. So the architecture that needed to be brought in first then would put the country in a better pathway to achieve universal health coverage as envisioned. Now, some people have highlighted in the past that this have been a very rushed process, and that happens many times when we are not very well organized as a sector. And I want to begin by highlighting that how education was able to beat us in two times. First time is that when we slept, we were devolved, number one. When we slept, we were devolved, number one, and that is why we are complaining that we need to redo the human resource for health to actually get a little bit more of a centralized system that enable better managing of human resource, which I believe in as a person. But two is that when the former president, Mwai Kibaki, woke up one day and said that primary facility education would be free, there were no teachers, there was nothing actually, so to speak. The system of education reorganized itself to make sure that the education system stands. The difference between then and now is that while he declared free primary education, we realized that he left the health of the same population in limbo because the Giro Bill of 2003, which is the architecture through which, if you look at the Kigali system is running on, or even the system in Ghana is actually running on our 2003 bill, which we did not implement as a sector, and we lost a chance there. When education was moving, we didn't move. We put ourselves together again as a sector in through the healthcare financing strategy of 2005. We documented and outlined all these reforms that need to be done to make sure that all of us are able to access care, and the healthcare system is well resourced to make sure that all the inputs are enumerated as efficiently as possible. The panel of experts, again, 2019, after the failed attempt of piloting UHC in 4 counties, a panel of experts that was put together by the last regime documented the NHIF we won. And in that, they have highlighted everything that needs to be done. The NHIF amendment of 2022 also did the same. Therefore, I want to first highlight to all of us that the journey to actually get to what we are trying to implement now, when we have political goodwill as a sector, is actually more than 21 years old. And therefore, the urgency, the scene speed is a speed of 21 years. And if, when you retire and you have time, if you could refer to these documents, because they'll tell you, they'll show you everything we have done is not something that we have come from the Bruce or this regime have imposed on the healthcare system. It is what our expert, our technical people have put together to get to where we are. Now, in the 2022 amendment, if you look at it, and please you should, you realize that it had suggested purely that we will have both the employee and the employer make contributions. The government was not funding anything in that system, the 2022 amendment. And we asked ourselves, when we have a healthcare financing system, as per the NHIF amendment of 2022, that ideally only allows for the employee contribution, but does not allow the employer and does not allow the government to put in any resources for the same. And then that becomes a contributory system that is pure and has no government tax-funded incentives or resources coming to healthcare. So we realize that is not the right thing to do. And we say it will be important to move towards a system that accommodates both the 20% who are informal, who have been contributing and carrying the whole burden, and we add the informal sector, who are the majority, who have been carried for long by the formal sector. That is the first key thing that is important. But two is that instead of only relying on contributions, we bring in government to put in tax money into the financing of healthcare. So we got what is called a mixed model, and that is what you see presented within the current reform that is being implemented. The other thing was that there have been a lot of opaqueness in what is covered by NHIF. We say it must be transparent. It should be published on daytime, and everybody should be able to go through the entitlement that they are entitled for, to enable them to see what are we all entitled for as a social insurance. Then, of course, I've said government allocates resources. The old system, government never used to allocate any resource. It is contributory, and therefore only those who contribute used to get an entitlement. I mean, the new one, we brought in a mixed model where government put in money for primary healthcare to purchase services in lower level facilities. And they also put money for emergency so that the facilities and the providers who have been struggling to actually admit emergency patients because they know there will be a bad debt and nobody will pay them, would stop actually, going at a loss when they are patients. That's how we came up with the consideration of a mixed model rather than a purely contributed model. The other thing that was important was actuarially fair premium, which is estimated in a way that all people pay based on. So this election then talked to several things. One, repositioning of NHIF structure and operation to the new mandate. And here, good people, the key thing was the board composition. If you look at the previous board, it had very few medical providers in terms of capacity. It also had fewer practitioners, so to speak. It had people who are largely not interested in NHIF functioning. But now, if you look at this board, which has an AMA, it has a representative of Informal, it has the DG, it has, if you look at the whole composition, including representative of the healthcare providers, you will see a deliberate attempt to make sure that the board is constituted with the people who want it to function. Because if NHIF does not function, then it's impossible to pay for services. Now, if we cannot pay for services, then it means the facilities go at a loss. So the board composition was critical. And when you look at the HEFLEP report, was written by a panel of experts, that is one of the things they highlighted that we should be dealing with. Number two is the increased efficiency in the claim management. Currently, the NHIF has been learning 4 systems, and we felt that it would be important to have one integrated system to begin with. And number two, the biometric registrations that have been put within the NHIF, because they have corrected the biometrics themselves, there were many that were not actually correct. And this has been proved when we have done the review. We have realized that we have, out of the 12 million biometric registrations that we have verified at the NHIF, 9 million were okay, 3 million have a problem. Now, the question would be, then that becomes a point of entry for inefficiencies where people are paid for services they have not received. And the ease of empanelment and contracting, and we say that all facilities that have been approved by the board should be empaneled. You don't need to see anybody for you to be empaneled. And second, when the contract is given, everybody who wants to provide services and qualify and have been given accreditation to that effect, then they should be contracted. So the issue of a special treatment for some facilities where others are suffering or having to go through a tedious process for empanelment and contracting, that was one thing that we also are dealing with within the system. The other thing that we are dealing with is the fact that we need to set up a quality of care authority. And this is because the discussion of UHC have largely centered on purchasing services, contributing money. But the issue of the quality of services that we are actually getting was never resolved. And therefore, people continued paying for services, but those services were not quality. Therefore, you realize that things like our maternal mortality rates, ideally, after many years of investment, have ideally stagnated. Now, dispute resolution was another thing. The previous NHIF was Alpha and Omega. They would be the one who decide what to pay, who to purchase it from, when to pay, how to pay. If a provider has a problem, they were also themselves the conflict resolution body. Now, when you go to such a body, then you leave providers in a very precarious condition where they have nowhere to go when the architecture is actually, the fact that the person who have wronged you is the one who is a dispute resolver. And therefore, if you look at the new architecture, this issue is completely solved by having an independent body that is actually dealing with this issue. The other thing which is of importance, of course, is moving from output, move to output-based financing away from input side. And let me remind ourselves that after devolution, for those who remember well, there is money that used to be called the user fee. And the user fee forgone was actually sent to our county facilities at some point, so that money was supposed to be redirected into improving healthcare facilities, including hiring of more human resources to be able to provide care within the public setting. However, that money was largely, diverted into other expenditures in the county, name them good mates, Pablos, Malam loads, etc. And that is how health consistently loses money, ideally, that was supposed to be within the healthcare system. Now, within this output-based financing, we agreed on this, that when a facility provides a service, we pay for the service. Now, that is a very key thing that we need to remember, because when you pay for a service, that means that the facility must be able to provide the service. Even if it doesn't like providing services, it should provide for the sole reason that it will be paid after providing. The only reason why the butcherman hires a person to roast meat is after he knows that the customer will buy roasted meat. And therefore, we need to trigger the healthcare system to start investing with a soft investment of a facility. That is employment of human resource. I need a physician, employ a physician, so that the physician provides the services, and then this physician is paid for those services that have been provided. So this model here, the majority of the resources that are being put will end up going to facilities or hospitals. And in these hospitals, it will end up triggering employment of human resources so that the doctor can provide a service, and then the facility is paid for that service. So now this is how we will trigger massive employment of human resources, doctor, nurses, clinical officers who are needed to give the service. Now, this then is what we call output-based financing. It incentivizes the facilities to put in place everything they need to provide a service. Even if they don't like hiring, they'll have to hire because it's an only point of entry for them to get the money. And then we came in and said that before the devolution, we used to have hospital boards and committees that were ideally a key component of management of these facilities, even lower level facilities. And I do believe that our healthcare professions have capacity to manage resources, even if not much. They can manage resources at a facility level. That is why we said if we push money into a facility and we do not create facility fund, then we have not helped our healthcare worker, because he or she needs to have resources that the money she has collected or he has collected, she can use it to quickly address the major constraint to the facility he or she is leading, to be able to provide better services for the tomorrow. So that is how we went into what you hear called FIF, the Facility Improvement Financing Bill, or Act now, was ideally supposed to place resources into the manager, who is a healthcare worker or in charge in a facility, to be able to address the current challenges. And the law says like this: when you provide a service, the social authority will pay for that service, and the money will stay in your facility so that you use that money to improve the services in your facility. You can hire some local workers. You can actually buy some commodities if they are lacking. You can buy some reagents if the facility does not have those reagents. And that is a model that we present to you this morning. And of course, needless to mention that our good country called Ghana did not go through the mixed model. They said they'll go through a taxed funded model. And when you see some of the economists who have not, health economists who have not really taken time to study models that have failed and worked within countries, you'll see they'll tell you, let us have a tax-based model. But good people, let's not lie to ourselves that we are a rich nation like America is. We have constraints in terms of budget. And when Ghana tried that, two things have happened. One, they got increase of coverage to 40%. They have defaulted in terms of the debt obligation. They have dropped back to around 30%. That is where Kenya is, even without trying. So we thought that it is good to have a two-prong model where there is tax resources added to health so that we have a pathway to pressure our exchequers, our assembblies to allocate more money to health through those two funds. And second, direct that money straight into the facilities where services are being provided. And third, have a fund that is contributory to supplement the money that government is actually providing. And that is a mixed model that we are using. So in a quick way then, that's what bore these three laws. The Primary Healthcare Act, which is ideally supposed to make us purchase services from level 2 and 3, dispensaries and health centers. The social health insurance that is expected to improve the NHIF of 1998. So when I see people saying you are killing NHIF, NHIF used to be National Hospital Insurance Fund. It changed its name to become National Health Insurance Fund. It has changed its name to become Social Health Insurance Fund. Any improvement have a reason, and it have migrated. Its growth is marked by also reflection of what it strategically means. So we are now a social insurance, as it was also in 2022, but it did not bring the solidarity principle to make sure that we contribute based on ability to pay, and then we assess based on need. The Health Act, that one is important for interconnectivity of the superhighway, removing the paperwork that we have within our facilities, enabling us to have patient data portability, so that I don't have to carry a file from one facility to the other. Whether it's a public, private, or FBO, I just need to go there with my ID and they pull my patient history, and then I'm treated. The issue of telemedicine is well included there. The issue of a track and trace of commodities for removal of counterfeit. The issue of financing, which is the SHA. So there are around 15 systems that are supposed to be inbuilt, provided into facilities, including hardware, where CapEx is covered, and of course many other things that are included there. The last one is what I've mentioned, that will make our healthcare workers to feel appreciated by also taking financial decisions no matter relating to their facility. If we do not appreciate the principles, then it becomes a difficult thing. So we have quality as a key driver, improving access, making this affordable, improving efficiency by our digital system, making it more accountable, not going through the, again, there's a human rights. And the key cornerstone is the solidarity principle, which binds us together in terms of what social insurance is all about. Now, I would highlight some few things so that I stop so that we have a discussion. One is that the key thing is that resource mobilization have always been a big problem for health. And when we mobilize, that money goes to brick and mortar. The finance architecture we have provided is the one that goes to soft investments that do not really require brick and mortar, but largely they require human resources, reagents, commodities, so that when you provide that service, the resources are actually available for that work. There is also the issue of infrastructure, ICT, connectivity for efficiency, as I've highlighted. The quality of care is a key overarching objective that we want to learn with. Now I want to highlight that. And of course, the other investment I've highlighted relates to human resource, the equipments, commodities, among others. The key thing is human resource, a key component. The flow and retention of funds in facility through the FIF. The communication of UHC to increase awareness and demand for services. And this is where we must all be there. The way you make resources as a standalone provider or as a hospital, then it is when you improve the communication, people are aware, they come to your facility, then you provide the care to them. And I want to interest you with the principle of digital kiosk. This is a time when a doctor can sit down, see a patient inside a digital system because they are entitled to log in, see a patient, refer them to a pharmacy, to a lab, which they choose inside the system. The person goes to the lab and the results come back, the doctor review them and prescribe medicine within the same system. the patient go to look for medicine in any of the pharmacies that are available, and the medical doctor sits down and provide the care to that person, whether they have a facility or not. That is what we call a digital kiosk. Is empowering a medical doctor not also reliant on existing hospitals that sometimes are exorbitant and tie down the healthcare worker to themselves. So the power is also given to a healthcare worker to be able to do what they're supposed to do. There's a benefit package which is full-fledged that I don't want to go through now because I've been shared many times. Then the issue is that the benefit package
I want to give you about 2 more minutes.
I need one actually.
Okay.
The benefit package that we have is far bigger than what used to be in NHIF, and it's good for us to review it and understand it. And of course, for those who work in government, there is a civil servant schemes and other schemes that we're learning within the NHIF as a special pools. The benefits will not be lost, and all the civil servants' benefits will be provided. For instance, we are only separating the benefits that are what an employee is contributing to, the benefits the employer is actually providing. But the aggregate benefits will actually not fall. So there is a consideration there that the employer will forget. The employer, any employer who wants to enhance benefits will actually enhance for the employees. The government is in high gear to actually do the same for its own employees. Over.
Okay.
Thank you.
Thank you very much, Mwai, for that comprehensive presentation. There have been many questions that have arisen from your presentation, and I have tried to group as many of them as possible. So I'll be asking you once we hear from Terry Rotich and Dr. Abdi. So I'd like to give Terry just 5 minutes, Terry, so that we give more time to answering the questions. That you could tell us the current legal position of SHA, because we know, first of all, there was a court ruling that declared the authority as unconstitutional. Yet the other day, the Court of Appeal gave SHA the go-ahead for the rollout. So where really, legally, does this stand? Because we could be going through all of this and then, a few days from now, when the court cases are ongoing, then, people are returned back. So where are we legally on the issues of SHA? Terry, I'll just give you 5 minutes, please.
Thank you. I hope you can hear me.
Loud and clear, go ahead.
Okay, thank you very much, Dr. Mercy. I will not talk about what the issue of the enactment of the laws. I think Dr. Mwai has clearly articulated on that. The acts, once the acts, the UHC laws, as we call them, were enacted on 19th of October 2023, immediately, particularly when the Social Health Insurance Act came into force, which is on the 22nd of November, we have faced some litigations from various parties. One of them being Joseph Enoch Aura versus the CS Health. That was filed a petition which we were served with orders on the 27th of November. This is 5 days after the acts are in force. And this matter is the sorry about that. So this is the if you look at this matter, the constitutional petition E473, because there was another one also by Dominic Masenya, and also another one filed by KMPDU. All these matters look like they were stayed for this one, now the one for Joseph Enoch Aura, to proceed and a decision be made because they were touching on the same subject matter. And so when you look at the court ruling that was delivered on 12th of July 2024, the court highlighted key issues that we failed to conduct sufficient public participation, and that the laws be suspended for 120 days for Parliament to undertake sensitization and adequate reasonable public participation before enacting the acts and amending the unconstitutional provisions. So now, when you go to the same day, actually, on that 12th of July, 2024, we immediately applied for stay of orders, noting that there will be a serious lacuna in the health sector, because if the acts are suspended, then there is no law in place guiding social health insurance. And when there is no law in place, then even the NHIF was not in force, because the Social Health Insurance Act had repealed the NHIF Act. And so when we applied to court, they saw the view that we have brought before them and granted us 45-day stay. The 45-day stay lapsed on the 26th of August. However, we filed an appeal, a civil appeal at the Court of Appeal, challenging the ruling or the judgment of the High Court in that matter. And on 20th of September, because we did an appeal and an application for stay pending appeal, because Court of Appeal was in vacation and we could not get a hearing, an early hearing date at that time. So we had to file for an application for stay. The Court of Appeal granted us stay pending appeal. And I will highlight one of the key issues that the court pointed out, and I wish I could just get it. The court noted that these laws have been with us for 9 months, and saying that we will revert back to the old system. And then maybe, because if they had failed to grant us the stay, it would have meant that we revert back to the NHIF. Then now we are successful at the Court of Appeal, we revert back to the SHE, the social health insurance. So court noted and said, this law has been with us for the past 9 months. The Social Health Authority is in operation. Let this matter be fully determined at the Court of Appeal. And so we proceed with the rollout. We proceed with the ongoing rollout of the social health insurance until a determination is made at the Court of Appeal, letting us know whether or not we actually infringed on the constitutional provisions or not. And so the status of the matter is that court allowed us to proceed with the implementation of the social health insurance pending the determination of the appeal. Because I think I needed to point out that issue, that they also noted that we cannot be, this is a very critical sector. The health sector is a very critical sector in that you cannot move people from one model to another model, and this is a new model that is being brought on board. So you'd rather just proceed with it, see how it goes at the Court of Appeal. Then if a final decision is made, then we can decide at that point in time. I wanted to highlight that, Dr. Mercy. I don't know if there was any other issue you wanted me to discuss on the what is the current status of the laws. So in terms of current status, the law is that the laws are in force. They are not suspended. The Social Health Insurance Act is still in force, and the same enables the Social Health Authority to proceed with the planned rollout. Yeah.
Okay. Maybe just to throw in one question, and I'm seeing even somebody has posted it. If it is thrown out, like what happened to the Finance Bill 2023, what happens? If it's thrown out at some point?
Sorry about that. Yes, so the likely scenarios of this matter at the Court of Appeal is that either the Court of Appeal will uphold the judgment of the High Court that the acts are unconstitutional, and therefore ask us to reenact those laws afresh. And that means then we would have to revert back to the NHIF legal framework that was then. If you look at the decision of the Court of Appeal, when they decided on the issue of whether, if this law is declared unconstitutional, then this other law, then we go back to the other previous law. So there will not really be a lacuna in terms of health service provision. The other likely scenario is that the Court of Appeal agrees with the submissions of the Ministry and the Social Health Authority that indeed we did carry out public participation, and that indeed these laws are, if you look at how the court ruled at the High Court, they noted that the object and purpose of these laws were very noble, and that the continued existence of the NHIF was unsustainable, and these laws were transformative. All this I'm quoting is what is in the judgment, that the laws are noble, the laws are transformative, and the laws seek to actually ensure that the new social health insurance framework is sustainable, because as it is currently, the NHIF is unsustainable and it would collapse. And I think that is part of the problems that Dr. Mwai has tried to highlight. And so court appreciated that. And it's also a major issue, the only issue that court pointed out was that the processes that were done at the National Assembly and the Senate was a bit rushed. And so they felt like they should be given an opportunity to remedy themselves. However, in terms of the objects and purpose of the laws, then the laws are okay. So those are the two likely scenarios, that one, either they uphold the decision of the High Court that it is unconstitutional, or we proceed with the new social health insurance.
Okay, thank you, Terry, for that. If other legal questions come up, I will let you know during the Q&A. So last but not least is Dr. Abdi Mohammed, who is the chairman, SHA. And Abdi, would like just to hear from you, first of all, about the rollout. It's been chaotic. So let's just start from the basics about our registration, both as individual citizen contributors or resident contributors, as employers, and now the key thing, which everyone here is, as a provider, because the system and everything since the rollout has just been chaotic and things have not settled up to now, because I can see in different platforms, people are not able to log in, people don't have credentials, or their facilities were captured wrongly by KMPDC. Just tell us about that being part of SHA and how you had intended to do this rollout. Dr. Abdi.
Thank you, Mercy. I think my colleagues have spoken to the reasons and the why and the necessity and the legal issues. So for me, I just want to explain just a few issues. As all you need to do is register with *147, or you go to Afya Yangu portal, or sha.go.ke, and you will be able to register. But if you are an employer, there is the employer's portal where you go to and register your business and declare your staff, who you will be paying for the 2.75%. Then if you are an employer, your first remittance will be end of October for the 2.75%. That is by November 9th, you should have submitted the 2.75%. But registration is ongoing in the portal, where you need to continue updating if there is any issue. And we are not changing the employer codes, even the byproduct, similar to what it was, but now with a portal, rather than doing taking those things, those files to banks and such. On the issue of as a service provider, I think what I talked about, you are empaneled by a different body, and that is KMPDC. Once you are empaneled, then you can you have the option and latitude to accept to be contracted or not contracted. So it's not mandatory, but SHA will empanel you within 30 days that you have been empaneled. But we have moved from 30 days, we are empaneling you real time. Because our system is connected to the KMPDC system through APIs. So we read directly from their registry, and we are able to see who have been empaneled. So we have removed the idea of what used to happen, which was You apply to the branch, you go through, I don't know what, people will plan which day they will come. Then you fill in forms. It's either approved or rejected at the branch. It goes again to the headquarters. Then you are told the board is not sitting this quarter, wait for next quarter. Then you wait for a quarter ends and there's nothing. You are told that was not on the agenda this quarter, wait for the other quarter. So all those issues we said is not necessary, and it's not in the mandate of a payer. There's someone else who will do that work. You cannot be doing both at the same time, the payer and the one who is going through that. So we said, let's allow that one to be, because there's someone licensing you. They have inspected, they have given you a license. They know what they have done, and they are the ones who are held accountable if there are any issues. So for us, we just empanel you within 30 days. The contract now is very clearly, it's simple. It's a sort of an SLA agreement. It's an SLA, sorry, it's an SLA agreement because we are using the Public Procurement Disposal Act as the main law because of the two funds that we have, which are the primary and emergency chronic critical illness fund. So they have general terms and considerations. So there is no much variation that we can do because they are very simple. But more importantly, the tariff and the benefits and the access rules are something that we have also gazetted as well. So it means also there is no variation in that document. So there is no negotiation and discussion under the table on how much you should be paid, who can you see, who can't you see, which benefit are you entitled to see or not. So it's clear. It's just one contract, similar. So the only difference is the level of services for each level of facility. And that is what now we have embedded as part of the schedule. So in terms of also the contracting bit, we made it much easier as well. And more importantly, there's a portal that should be up, I'm hoping by end of tomorrow, but at worst, it should be up by Friday. That now makes it easier also to be contracted. You are in panel, you see yourself in the list, you are comfortable with the prices, you look at the terms, you go into the e-contracting, you fill in your details, you sign off, and you send online. Then we, on the other end, we take it up as it is, so we don't have to deny you to be contracted, like the way you are told sometimes in other insurances or even NHIF, like this area has too many. We want to give that too many options to the patient. Let the patient be the one who decides where they should get service, not ring fencing service providers for just a few groups of people. So that also is very open and transparent. We don't stop you from being onboarded. So once we do that, then now you provide services. So what happens is we give you a portal. For now, that is the stopgap measure. But in the long run, by the end of this quarter, we want your HMIS system. If you have one, you connect to the HIE. If you don't have, we give you HMIS for free as well. It's part of the digital system that we are enrolling. So if you have HMIS, well and good, you use the HMIS that you have, but you make sure it can connect to the HIE. On that one also, we have published the portal to connect on how to connect. There are few software vendors who have managed to connect their HMISs and they are ready. So what does that do? That allows us you to see the patients end to end, and it allows you to submit your claims end to end. So you don't have a different portal to log into. For you to say, I want pre-authorization, I want to check eligibility, I want to do. So you don't need to have many portals and systems to log in. You log into your HMIS, you see the patient. Once you close that encounter, it does two things. It shares the health record for the patient into the HIE, which is the shared health record, and it also sends the claim in real time. So you don't need to hire another group battalion of patient staff to do claim systems and all that. So that is the future, but for now you will have a portal that you will log into where you can do eligibility to check the patient, whether they are registered, whether they are available, whether they are paid up. And then you look at their benefits, whether they have exhausted or not, and you provide the services. So that is also what's happening now. The other thing that we have done is we are trying to move away from creating another biometric devices for identification. So the devices that you have had for NHIF or for SMART or for SLED, whichever devices that you have had in your hospital, is the same biometric machines that you will use. You don't need to invest in another one. So that is also another issue that we are moving forward to. So that is in general on the provider side. I think I have touched on everything as expected.
Yes, yes. So that's okay, because some of the issues will answer from the questions that have been sent, and the questions are very, very many. So I've tried to group some of them. The first one that's really recurring across from many people is the issue of civil servants cover and having a comprehensive medical care for medics. So the issue here is that the medical allowance, like civil servants, the medics here, the doctors had to forfeit their medical allowance so that they get the comprehensive. But in this case, they will be subject to 2.75% with no added value, because they'll be paying high premiums and they forfeited their medical cover, like they're stuck between a rock and a hard place. So what happens to them and the issue of a comprehensive medical cover? I think, should I give this to Abdi or
Yes,
Nwai?
I can answer. It's okay.
Okay.
So
Then we continue with that.
So the 2.75 is for everyone. Understandably, the enhanced civil servant cover was a benefit to its workers from the employer. That benefit is not disappearing. What has just happened is you will be given you will be given an extra benefit on top of what SHA is providing. And this is a discussion, and this is the other thing that I would like, and I have urged many times, that the union and all the associations and their representatives to engage their employer and have this discussion, because NHIF was just an agent that was receiving money, being told to provide this service. Same for SHA, it's just an agent receiving people money from individuals, employed and self-employed, providing services. So if you have extra benefit, like housing allowance, I don't know, medical allowance, now you engage that with your employer. But more importantly, with the team here, we have been pushing very hard for civil servants to get their extra cover other than what SHA is going to provide. And that is on course, and it will be done before the end of this month. That there will be another cover on top of what SHA is going to provide for civil servants. That is guaranteed.
Okay, thanks, Abdi. The other recurring question, colleagues have tried to group the questions based on the recurring theme. The other one is on the premiums vis-a-vis what people are getting. So, for example, the examples that have come up is on one, the capitation of 900 to the primary care per household per year. The question or the comment there is that this is not enough. Like if you look at consultation for one person, the labs, the medicines, that will not be sufficient. The other one was on NCDs, issue of, for example, diabetes, where it is 44,300, asthma is 700, and it's per household per year. You have dental, of course, which was 2,000. So the question here really is, for the premiums that people are paying, the 2.75%, or even when they get to pay out of the 2.75% versus what people are getting as benefits really does not make sense. Abdi, you want to take that?
Yes.
Okay.
I can. So this is the thing that I want colleagues to understand. When you see outpatient, and this is, for me, it's, I would say it's more of lack of knowledge, because or we have been too transparent on what happens. So NHIF used to pay providers 1,200. I've never seen anyone shouting before, and it has been doing capitation for the last, I don't know, 5, 6, 7 years. It's just because you did not know that providers were paid 1,200 and now it's 950 is the only difference. So, but as a beneficiary, you used to go to a facility, for example, like Landan, for your outpatient services, and you used to walk in and walk out, but you never knew what Landan was paid because there was nowhere it was published. So today, let me declare it. What they used to get was 100 shilling per person per month. That was the amount that we used to get. So what am I trying to say? All I'm trying to say is providers know what is it that they how the provider payment mechanism works between them and the payer. For you, what you need to ask is, do I get the entitlement as expected? Can I get consultation, lab, pharmacy? It's not in your space to now have a discussion of what is the cost or how has this been costed? What is this provider payment mechanism? Now that one is now between the provider and the payer, and majority, almost all of them, are comfortable with that provider payment mechanism, and they are happy with the amount that has been suggested, because now they can see there are more patients, because that's paid for by the primary health care. And that's an entitlement to all Kenyans. So meaning every Kenyan can walk in and out to a primary health care facility that has been contracted. Number two, prior to this, there was no chronic disease investigations, none. everything was being done under your outpatient. And the same will continue even now. So you are capitated to a facility, you will be able to, or you are in this PCN, you will be able to go and get your normal lab, drugs, the usual consultation. But we have added extra tests, specialized tests, which you need for purposes of continuous monitoring, so that people understand what is this, how is your condition going forward. And those are the recommended WHO tests annually that you need as a patient. And this now helps the doctors and the consultants or the medical officer to see how is your compliance, how is your disease progression. So it's just to monitor. It was never there. So we have introduced it for the first time. The one that we are being accused of, it's low. The lowness is not the issue. The issue should be, can I get these services? So for you, what you should be asking is, if I go and do my HbA1c, or which facilities have we contracted to do the HbA1c? So what now that facility, once it agrees to our prices, for you, what you need to worry about is, have I gotten the services? Yes or no? If I've gotten, then it's beyond you to now start questioning what is the amount or how much or why, or it's too little. Then 3, dental was never there before. It's a new thing. So also again, we have published. Now we are being accused for publishing and saying there is a benefit that we want to introduce. Finally, this is social health insurance. So in social health insurance, everyone contributes equitably based on your ability to pay. Everyone gets services and benefits equally based on your needs and your diseases. So there's someone who will pay 300 shilling. There's someone who will not pay anything because they're indigent. There's someone who will pay 500 shilling, and there's someone who will pay 1,000 shilling. So you pool that resource into one basket and come up with a benefit. Because what happens is, if we don't do that, then we are in the space of private insurance. So everyone pays for what they want, how they want. We have moved away from the issue of UHC and social health insurance. We are in the space of private health insurance. It is what you pay, you get what you benefit. But despite that, so you need to look at, other than the people who are paying very highly, who are 5%, understandably, some of the doctors fall in that group, or majority of the doctors might fall in that group. The rest of Kenyans, 62% will have a reduction in their premium. What they were paying to NHIF was higher than what they will start paying. So meaning they will have a reduced amount to pay. Another group of around 20-something percent to 30 will have a marginal increase of up to 1,000, 1,500 increase per month. And that's the reality. And this is just a proportionate system that we have come up with, which is fair compared to if the system we had, which was regressive. If we said we will do progressive contribution, then we will do the way we do payee. So we will say someone who earns 20,000 and below will not pay anything. And then we start with 5%, 10%, 15%, 20%, 30%, 35%. Now that is progressive taxation or progressive contribution. We have not gone that way. What we have said is, let's do proportionate, let everyone pay to their ability. And that's how we ended up with the 2.75%, which was fair for everyone to get the benefit, the kind of benefit that we would want. But if we now need to increase the benefits, then we will have to increase the premium or the tax funded schemes to be a little bit more. Then, okay.
No, just finish.
So finally, when you look at your cover, because you are employed currently, and you are paying, let's say, 2,000 or 5,000 a month, keep in mind that there are many of your relatives or family who are paying way less, 300, 500, 400 shilling. So don't look at individually, but look at societal, especially the people that depend on you and what is it that they are benefiting. So today, if you are told to go to the market and get a cover for 3,600 for a family of 5, 2 adults and 3 children, I was told the only thing that you will get is last expense cover. That's what you will be entitled to. There's no other benefit. But here we are with cancer treatment, surgery up to almost 1.2 million, chemo, radio, PET scan, CyberKnife. Just think about anything in terms of cancer treatment, renal, transplant, outpatient end-to-end for all your needs, outpatient visits, inpatient up to 800,000. So surely there's no cover that can give you that much benefit for 300 shilling. It's impossible.
Okay, thanks, Abdi. Let me give the next set of questions to Mwai. And this is around how the system is handling patients with other insurances. I was seeing a bit of some people may need to pay out of pocket, which beats the whole purpose of universal health coverage, because as the recurring theme here is that the benefits given versus what they are getting will not be enough. So an example has been given here of an inhaler, which is 2,000 shillings, yet asthma is 700 shilling per year per household. So that's not sufficient. So Moi just tackled the issue of paying out of pocket, handling other insurances. Then in the same breath, because when you are doing the presentation, there was the bit about, just give me a minute. There was a bit about SHA handling health financing, but what about service delivery, human resource for health, the health information systems, medicine, supplies, and non-farmers, and the issue of leadership and governance in hospitals as 6 of the key building blocks for, a healthcare system. So you've addressed the issue of financing, yet all of these are either lacking or wanting in the facilities. So how is this going to work? You've collected money, but if patients go to the facilities and there's nothing, then they've more or less just paid for zero. Moi.
Thank you, Mercy. So I want to first highlight something that Abdi have touched on, and I highlight that when you look at the way the capitation amount is estimated, you do the cost of diseases that will be treated at lower level facilities, for instance. You get the total amount. then you divide that total amount with the population, because you want to say that this is the amount that ideally the facilities will be compensated for each of the households that live within that area for it to seek primary healthcare services as many times as they need. As many times as they need. It is different from fee-for-service, which people are interpreting the 900 to mean. That is why people are finding it little. But when you look at it as a capital resource allocation for the facilities within a certain surrounding to provide the outpatient or the services that have been highlighted to the population living in that area as per the demand of the services that they require. So that is the difference between capitation model and the model that is fee for service, which is what people are interpreting the 900 to mean, which is not. The other important thing is that the Social Health Authority envisions that there are people who require extremely expensive healthcare services, but not the service itself, but also the other provisions that facilities provide in line with the status of the person. For instance, a member of parliament getting an extraction, a tooth extraction probably, may actually go to a facility that charges 50,000 per each. Well, the same tooth can be extracted with 300 in a facility. Now, the difference could be the status of the facility they get into, the treatment, the food, the room, and many other factors. So the social insurance provide two things. One is contrary to the past where majority of the middle class never used to use their NHIF. As of now, they will have to use because the law is clear that the Social Health Authority is a first charge. That means that when you go to the hospital, they will charge the tariff that you qualify for under the Social Health Authority. And if the facility you have gone to is charging more than that, for instance, if you go to these more expensive facilities we have in town, and you realize that, for instance, investment for a cesarean section is at 30,000, 32,000 there, and you're in a facility that is charging 150, the first charge will be that the social insurance will pay the 30,000 or so off the 150. And then your complementary insurance will pay the rest. Therefore, any other insurance that you'll take in health, including the employer scheme for civil servants, for instance, will be covering benefits above the social health insurance benefit. And because the law is clear that the first charge is a social insurance, that means there is no one who contributes who will not claim unless they don't get sick, which is a blessing. And I don't think anyone would want to get sick for the reason, so that they kind of, claim. So I wanted to make sure that that is clear because it's a complete move away from the current setting where the first charge was ideally not always a social insurance, and the entitlement was not clearly labeled, and therefore it was difficult for other insurances to price the premium. So we expect to see any other private insurance to either drop the premium or they increase benefits significantly. Number two, and more importantly, is that we have had a big problem with the capitalization of KEMSA, and the government have moved in to provide funds to make sure that KEMSA is well stocked to be able to service the county facilities when they demand for commodities. By the time we did the evaluation, the KEMSA refill order rate was approximately 38%. That means for all the orders that the county give to KEMSA, they were only able to fill 38. Now that is pathetic because it makes the county facilities not to have commodities. Now what we are saying is this. The digital system roll out what is called the LMIS. This is the logistic management system, which makes the county facilities, the private facilities, and the public facilities to see the stock levels of all the suppliers that we have in country, be it KEMSA, be it MED, be it any person in this meeting who probably could be a supplier of genuine commodities. The one is genuine commodities. That is why they are being tracked. They are able to see the orders that are available there and the prices. And therefore, you are not only limited to buying commodities where you must buy, but you buy where there is competitive pricing. They can be delivered to you. And why will you be buying? You'll be buying because the moment you issue these commodities, whether they are reagents or whether they are medicine, the social authority will pay you. So as it pays you, you build your own facility capacity to order and reorder because the money is coming straight to you. And therefore, you get commodities that you can be able to, figure. So the first thing we are doing is to increase the KEMSA field order rate, and therefore it will be, and also integrate the LMIS so that commodities become more available, and our county government facilities as commodities, but also the private is able to access commodities in a competitive market, and they get the better prices for the human resource. Again, I say that it is important. There are parallel discussions that are going on. For those who may know, we have a team that is working on human resource for health. But more importantly, we are also saying that when you provide resources to the facility and you pay for a service that is needed, it means that you will force facilities that have refused to employ doctors because, for instance, they have no money. But we are paying for the work this doctor is doing. That means there should be money to pay them. And the money is coming directly to them. So this will be a complete revolution, forcing the facilities to reallocate their resources to hiring the right human resource. And that is how we see the output-based financing approach, solving the problems themselves without having to force or keep on forcing our union to, keep on pushing counties to hire, and they're not hiring. For a county to be able to receive resources, they will now be forced to have the person providing the service. It beats logic not to have that person, yet you'll be paid when they work. So it is just a reorganization to trigger the demand for having the right human resource in our facilities, so to speak. The information system I will not talk about because we have highlighted. In a nutshell, Dr. Massey, I just wanted to highlight that the key building blocks are being worked on. The healthcare financing is just one of them. So it is us as a health sector to actually work together to boost our comprehensiveness in pushing the government to largely deal with all these issues that we are talking about pertaining to a strong healthcare system. It is a moment for the healthcare people themselves not to sleep the way they slept at devolution, but to take this opportunity, make and re-engineer themselves for success. Thank you.
Thanks, Mwai. Colleagues, we were supposed to end at past, but we have over 200 questions. So I want to request us to extend by about 30 more minutes so that we can get another set of questions answered. I can see some people are saying their questions are not being answered. We are cognizant of that. And so I want us to request that we extend till 9. So you can just show me a thumbs up if you're okay with that extension so that we have a lot of the issues answered as much as possible. Thank you for the green light. Then secondly, we'll give about 5 people an opportunity to ask their questions live on audio as we had promised. So kindly, if you want to ask your question, just raise your hand. The admin will be able to see you and will be able to give you an opportunity. Kindly ask a question that has not been answered so that we use this opportunity to get as much as possible answered. So as we do that, I want to throw two questions to Abdi and then Terry. So I'll start with Abdi. There is a recurring question here. The people on the call are, as much as they are citizens who need to register individually, they're also providers, and some have been providing services under NHIF. So the big question here is not even will they be refunded, but when will they be reimbursed for services that were offered under NHIF now that there's a shift to SHIF? That's the first one. The second one is, with this 1 week where there's been chaos, a lot of things happening, and some people have offered services, will there be a reimbursement, and how will that claims process look like? So Abdi, just go with that, and then I'll get to Terry, and then we'll open for people to ask the questions live. So when will people be reimbursed, and how will the claims for the last 1 week happen?
Thank you very much. On the issue of previous, the NHIF bills, all that is now a liability for Social Health Authority, and that payment will be done by the Social Health Authority. We have been doing in installments that have been happening, but now we want to push for that payment to be concluded as soon as possible. But it will be coming regularly in 2 weeks, in 3 weeks' time, so that we are able to clean up and clear that liability. On the issue of the last 2 weeks, yes, this SHA will prioritize as a sign of goodwill and as a sign of not wanting to have historical or bad debt, because it's easier to reconcile now when the claims are fresh. So we will prioritize this as early as end of October, or as early as late as sometime mid-November, just to be clear on this 1 week, latest this second week, claims that will be arising because of the issue of not being able to submit digitally. So yes, we will prioritize the current claim and clear them before they become a challenge later to address them.
Okay, thank you for that. Terry, the other question recurrent is, why do we need to register again, yet NHIF had all our biodata? Why is SHIF mandatory? Isn't there supposed to be an option for an opt-out, especially in light of the hefty premiums that we have talked about? And is there any penalty for not paying or not being paid up under SHA? Terry?
Yeah, yes, sorry, I was busy typing some answers. I will start with the last question you just asked, whether there are any penalties. Indeed, there are penalties for failing to remit your premiums. And the penalty is not so high because, again, we did not want Kenyans to bear the burden of, I didn't have money now I have money. I want to pay, yet the penalty that you charge is so exorbitant. You see, like sometimes the way HELP has been charging students when they default on the loan is like 5,000 shillings. So here we were really cognizant that this is a health issue, that we wanted to reduce out-of-pocket expenditure. And so you find that the penalty that is given is 2% of the premium. So you find that if your premium is 300 shillings, I will use the lowest, it is 2% of 300, which is 6 shillings. Or if, let's say, if it is 2,000, 2% of that is I think 40 shillings. So you find that the penalty, yes, there is penalty, but the penalty is not so high. The issue of why don't you've asked about migrating, why should we register afresh? You have our data. I've also seen in the comment section that there are a number of people asking, why did you migrate my data without consent? So there are two groups of people here. One is saying, why can't you just migrate my data? This is NHIF, and there's another group saying, why have you migrated my data? So as per the legal notice number 147 of 2024, which was gazetted on the 20th of September 2024, it allowed the SHA, or it mandated now the SHA to transfer all NHIF members who have been verified using the relevant existing government databases to SHA. And this was to cure the problem of, you already have my data in NHIF, why can't you just migrate that? So it is allowed right now as per the law. We needed the lawful basis. We worked even with the Office of the Data Commissioner, the Social Health Authority, and the NHIF are all registered as data protection, data controllers and data processors. You find that Social Health Authority has taken over all the assets and liabilities of NHIF. So including even member data, all forms of data has been transitioned to the Social Health Authority. All assets, all liabilities were moved to the Social Health Authority. These are the same people who are handling the data. And I was just trying to answer the issue of why did you forcefully migrate? It is not that you were forcefully migrated. This is the same organization as Dr. Mwai had alluded in the beginning. It is a revamp of the NHIF, but it is the same organization that has been providing healthcare services that has just been revamped. So it is allowed right now in the law. You had asked another question about whether SHIF
mandatory. Can you
yes.
opt out?
No, as per the law, the law says that every Kenyan shall register as a member of the Social Health Insurance Fund. So SHIF, out of the three funds, SHIF is mandatory. And it is mandatory for the reasons that were provided in court and for the reasons that Dr. Mwai has provided for, as alluded to, the issues of sustainability of this fund, that we all need to contribute to this pool for us to be able to benefit all Kenyans. And that is why it was very clear it had to be mandatory. Remember, for the formal sector, you have been always deducted your NHIF premiums without without consenting, without even knowing. You just find it in your payslip. For the informal sector, the contributions were voluntary, a 500 shilling premium, which no one even knew how was it arrived at. How was a person who was contributing 500 going to be done for dialysis at 9,500 sessions for per 2 sessions per week? The maths will, again, that is something that was deliberated even at the court, at the High Court. And so the issue of mandatory, SHIF is mandatory for issues of sustainability of this fund and to enable SHA to be a strategic purchaser of health services. And how do we enforce that? You remember that the key issue that is in court and is being deliberated at the Court of Appeal right now is the issue of the Section 26(5), which now tries to ensure that every person who is registrable as a member under the Act produces proof of compliance with registration and contribution to SHIF. So you have to produce a proof that you're registered as a member of SHIF for you to access any government services. This is something that is still being deliberated at the High Court, at the Court of Appeal, sorry, but the High Court noted that this form of sanction, this form of enforcement is necessary for this fund to succeed. And so that is one way in which, if allowed by the courts, we will be able to enforce the mandatory nature. And it is more so on the informal sector. For the formal sector already, it is already being enforced. SHIF is mandatory for the formal sector. It is just deducted in your payslip. It is only in the informal sector, and this is why we had to bring in the equity and equality.
Okay, thanks, Terry. also we have Margaret Masharia and Mercy Mutua, actuaries from SHA, who are also answering some of the questions at the Q&A. So you can just check on some of the answers or the answered questions that they are typing the answers to. So we have, I'll start with William Chaka. Kindly just ask a question that has not been tackled yet so that we have room to answer as many as possible, and then try to be as concise as possible. Chaka? Kindly unmute. Yes, and go ahead.
Okay. I have a question. For example, you have a case, an emergency case, and at a level 3 private hospital. Hello?
We can hear you. Go ahead.
Okay. For example, you have a case, an emergency case in a level 3 private hospital. Then on assessment, you find that case is need an admission. So you have to do first aid before you refer that patient and for further investigation. So how will you going to claim your money and yet the patient will going to be admitted in another facility?
Okay, thank you for that question, Abdi. Please note that one. Dr. Ayaya, kindly go ahead. Please make your question as brief as possible.
Thank you, Mercy.
Okay, another question. Another question.
No, kindly one question per participant. So it's okay.
Okay.
We go to Dr. Ayaya.
Yeah.
So to Dr. Abdi and the team, could you kindly clarify when I go?
Oh no, Dr. has dropped off. Abdi, okay, she's back. Doc, just
Hello.
unmute. Yes, go ahead.
I'm unmuted. I was
Yes,
just saying that in case I go to a facility, I have a procedure that requires 30,000 and SHA only gives 10,000. What happens to that patient?
Thanks for that. Abdi, I think you can answer those two questions as we admit another set of 3 people so that they can ask their questions. Abdi?
Thank you. I think the reason why we published the tariffs and the benefits openly is so that people make those choices knowing very well where they are going. The patient will top up. If they have gone to a facility that they know this charges 30,000 and the benefit says I am entitled to 10,000, they will pay that 20,000 extra. But they have an option to go to a facility that will charge the same 10,000 and they will get the same services. And this is very common, even within the same hospital. We all know that if you go to a hospital, you can get a price of 50,000 to 250,000 within the same hospital for the same service of normal delivery because of where you have slept. General ward, semi-private room, private room, VIP room. You will pay from 50 and all you are doing is the same thing, which is normal delivery. So that is the autonomy that we want to give to the patient to decide what exactly do they want and where they need to go to for those extra services that they want. On the issue of emergency, the facility that has done the initial resuscitation will bill. You don't have to admit a patient for you to say you have given an emergency services. So you do your part. Because you have called in the ambulance for the evacuation, then that now you bill, and then the other facility now will handle the rest in terms of admission and all that. So as a facility that's providing emergency, you just provide the emergency, you bill what you have done. And that's how we have designed that part of the emergency.
Okay, thank you, Abdi. Let me go to Gilbert Korir, then Lois Mutai, and Ben Taumunge. So please, one question, concise, that has not been answered yet. Gilbert?
Thank you, Mercy. I read somewhere that upon fund maturity, Anti-snake venom will be offered 6,600 for the first dose. And my question is, so suppose patients are bitten by snakes before these funds mature, shouldn't the facilities be giving these anti-snake venoms? And suppose a patient again will require more than one dose, what happens to them?
Okay, thank you for that. Dr. Mutai, go ahead.
Hello, thank you so much for the chance, and thank you for the good education. Now, my question is, the previous NHIF, for people who are on comprehensive service as civil servants, they retire, they are dropped to Mwananchi cover. What is the plan for such people with this cover? Because if somebody was senior civil servant, you're on comprehensive cover, the fact that one has retired, unfortunately, didn't honor the fact that you contributed so much to this country before. There was no arrangement for you to even pay more and get the comprehensive cover. So this new system, does it take better care of people who've served the nation until they have retired? Thank you.
Thanks, Dakari, for that. Benta, go ahead. Benta Omonge, kindly go ahead. Just unmute yourself, just in case you're speaking and you're still muted. Okay. Okay, I think we'll answer those questions. Abdi, I want to give you the question on the anti-snake venom. And then Mwai, I want to give you the question on the retirees and the comprehensive cover. And in addition, let me add other groups of people that people have asked in the questions. This is persons with disability, the elderly, the widows, people who have not yet registered to the scheme. What happens to them in this new scheme? So those special groups of people. So let's start with Abdi and then Mwai.
Thank you. Any benefit that you find hasn't been allocated resources, for now, it's because of the available or the projected revenue that SHA will collect vis-a-vis the benefits that we are going to give. So all those aspirations, the reason why we have all that package and all that is just to tell you that this is what we want to do comprehensively. But we also need to be realistic and live within our means. So we only allow to proceed with things that we know, yes, there will be enough resources, then we can provide this service based on the resources that we have collected. So all benefits in the future, that is where we are heading. And this is why we have a mixed model, contribution plus tax-funded funds. So we also need to now also, as individuals in our own small ways, to lobby our members of parliament to allocate more resources to those two funds. Then we can increase the comprehensiveness, the depth and breadth of these benefits. That is for all of us to push and get extra. I'm sure no one will propose we increase the 2.75% to 10%. So I'm just looking at how do we input the other two funds to increase the allocations for those two other funds.
Okay, thanks, Abdi. Mwai, on the issues of retirees who had a cover, the people with disability, just those special groups of people, elderly, widows, what happens to them?
I want to highlight that the social health authority is for all of us, regardless of your age, your income, and diseases that, of course, each household could be facing. So when I look at it, then I would want to highlight that the Social Health Authority has no exclusion for age, and therefore everyone is a member. The elderly, ideally, are the ones that the government is expected to pay for under this scheme to take care of the senior citizens. The requirement for registration and contribution, of course, is not relaxed because that should happen. For the disabled persons with disability, then those are part of the people that the government is also paying for, as well as the indigents. So when you remove those, then the remaining ones are the payroll and non-payroll people who have some income. And these are the ones that the law is that we are charging 2.75 for each. I hope I have answered, Mercy.
Yes, you have answered. Let me take the last set of 3 questions. There's Dr. Abdulaziz Samperu, Chule, and Marcus. So we start with Dr. Abdulaziz. Just make it very brief and to the point. 1 question, please. Go ahead, Dr. Ari.
Hello, good evening. I hope I'm audible.
Yes, you are. Go ahead.
Yeah, so just to follow up on what Moy had said about, I just wanted a clarification on those the elderly, the senior citizens. Like, are we waiting for that government to fund their share? I mean, the contribution. That's just by the way. The other thing is that the public facilities, which we were like. The contract of the NHF used to send money, the reimbursements to the facility accounts. Are we onboarding with the same, I mean, facility accounts and all those framework? There will be a new way in which the SHA will be doing the disbursement to the facilities. Thank you.
Thanks, Dr. Ari. Chule? Chule, just unmute and ask your question. Okay, Chule is not ready. Let's go to Marcus.
Okay, thank you. Yeah. My question just to the lawyer on that legal notice that of 20th September. Now, could you comment perhaps on public participation? Because this is now people, I think this was an amendment after public participation has been done. So I don't know. Maybe the lawyer can comment on that. And then maybe to Dr. Mwai on the issue of the informal sector. You say they're the majority. So how much are you projecting to collect from the informal sector in this first year vis-a-vis what you're collecting from the payroll? And then lastly, you said one of the challenges with the NHIF or the separate funds was too many funds or pools, whatever in NHIF. But then in SHA, we also have 3 separate pools. I don't know, maybe you can comment on that. Is in that also a problem? Why could we just have one fund for everything? Thank you.
Thank you, Marcus, and thanks for being concise. Mwai, you could take the questions by Marcus and including the question on when will the government pay for the groups of people that it needs to pay. Then we go to Terry, then Abdi.
Thank you. I begin by explaining to him that we don't have different pools because all the members of the SHA are accessing the same benefits. So we don't have a different group accessing different benefits within the SHA. So when you look at it like that, then you see you have one pool of, you have one social health authority that is providing similar services to all Kenyans, provided they are members. So that's different from the 90-something pools that we had, where each group had its own benefit entitlement and costs. So contribution, as well as the payments and the benefits were different for each of those pools. So here we have one SHA, one benefit for all Kenyans. Number two is that, well, the expectation of the formal sector is that they provide up to probably around 40 billion in terms of correction for this year. The expectation is that the informal sector would probably provide up to around 53 billion, probably giving us a total of around 93 billion. The reality is that the informal sector is a bigger part of the economy. If you look at our economic indicators, and the economic survey is the biggest indicator that you could look at, you'll find that the informal sector is bigger than the formal, and therefore that is where more correction will come from, and therefore that's where we also expect to get quite some tough, in enforcing the contribution, because the country have been, lazy to only enforce the correction for employees because it's easy, because you interact with them every month. But now we are moving to enforce to the non-salaried who have resources. That means they are not indigents, and they are not elderly, and they are not in consolidation, so they are not being paid by government. They have resources that they can pay the premium. We are moving towards also enforcing for them so that we treat the payroll and the non-payroll person the same way. I think this one.
Yes, those are the questions. Thank you. Terry, on the issue of public participation.
Yes, thank you. For on the issue of the amendment, the legal notice published on the 20th of September, this was as a result of the public participation that we did, and the same was a culmination of the recommendations from the National Assembly Committee on Delegated Legislation, where they guided that for them to approve our regulations to pass, then we needed to do a corrigenda. At that time, they advised us to do something called a corrigenda, which is also more like an amendment. However, when we submitted the same, it went to the AG. The AG guided that it can only be done through a legal notice or amending the regulations. And so this is part of the public or outcome of the public participation exercise that indeed the verification, the transfer of or migration of the data of members. Yeah.
Okay, Abdi, just answer this question, and then I have one last question to pose to you on the reimbursements. Will they be reimbursed to the facility accounts, or what is the plan moving forward?
We will reimburse to the facility accounts that each facility has. There will be no collective account for county facilities. So each one will have its own account, and we will pay to that account so that FIF can be implemented.
Okay. Then now the last question I will ask is on cancer patients where there might be a crisis of recurrences and metastasis, because I'm told the cancer patients who are to get their second sessions of and third sessions of brachytherapy did not come. Reason being the benefit. So for example, brachytherapy treatment has been cut down to 40,000 per household. Previously, NHIF was paying 2 sessions, and the patients were able to use their spouse's card for additional treatment. So this cancer care and the additional cycles, why has it been cut to 400,000 per household? And so how are people supposed to pay for diagnosis, lab work, surgery? What happens to a household where they have 2 cancer patients, yet this is not enough? Abdi.
So what we have done is we have looked at the utilization of the cancer treatment from the NHIF data. So you realize that by prescribing how many sessions, what you are doing is you are disadvantaging certain cancers and advantaging certain other cancers. So you will find someone who has cervical cancer needs 24 radiotherapy sessions. I know you guys will beat me, but it's an example. So I'm not saying exactly that's the thing, but you will realize that someone needs 24. Instead, what was prescribed was 20 sessions. So meaning 4 sessions have been missed. But the same person is entitled to chemo for which was simple and complex chemo. So, but when you look at the guidelines in terms of treatment, it says 24 sessions and 3 brachytherapy. So now it's easier to give that person to do the 24 sessions and the 3 brachytherapy without them depleting the 400. And for them to complete their cycle, their treatment, as a guideline expects it, rather than being told pay 3-4 sessions out of pocket, then pay another 3 brachytherapy out of pocket. So what this was doing was people who are poor were doing the 20 sessions, then stopping because they don't know, they don't have money to pay the 4 sessions extra and the 3 brachytherapy. Then they come back a few months down the line with complications because of undertreatment. So now NHIF was now willing to pay for complex chemotherapy, which was now more amount. So we realized that was unnecessary in terms of undertreatment. Then you are willing to pay for advanced treatment 2-3 months down the line. It did not make sense. So we have said we follow the guidelines, and this is where now the issue of chronic and critical illness fund comes in. So if you have exhausted your amount under SHIF, then we will be able now to escalate your treatment to the chronic and critical illness fund to step in for you to complete your treatment. But your treatment should follow the guidelines as per what has been prescribed to be the treatment guidelines from the National Cancer Institute. Thank you,
So
everyone.
the question is, so for example, if you have 2 cancer patients in a household, and this has been reduced to 400,000 per household, will it be sufficient?
I have to recall that benefit clearly. Is it per household or it's per individual?
So the question on the chat says per household.
That's why I am not certain. I need
Okay.
to check on that, whether it is, I don't recall whether it was per household or per individual. I will have to check and confirm, and then I will be able to answer. Just give me a few minutes.
Okay.
You can
So,
ask Margaret. I think she can quickly respond to it.
Okay.
Yes, Dr. Abdi, I can confirm it's per individual and not
Okay.
per household, the cancer limits. And
Thank
as
you.
you're saying
Thank you.
rightfully, that from analysis of how the national scheme members have been utilizing the oncology package, this is inclusive of all the scans that they do, the PET scans, the MRI, the CT, and the chemo, the radio, brachy. 90% utilize a maximum of 400,000. And only 10% their bills go above the 400,000 limit. Hence why the change in how the financing is done. Remember that even for the basic chemotherapy, where the limit was 25,000 for every session, you'll find that most of the patients used to utilize less than the 25,000, meaning they lose the opportunity of realizing the full cost of what was allocated to them. Hence why now the limit is just one figure and it goes as the billing is being done. But right now the approvals will be done according to that NCCP MOH guideline for the adult and childhood cancer differentiated care model. Thank you.
All right. Thank you very much, Margaret, for that. Colleagues, I think most of the issues have been tackled. I can see there's still some other questions pending, but I think most of the issues that we had have been tackled. So allow me to give each of our panelists just 1 minute to give closing remarks. Let me start with Terry, Mwai, and then Abdi, and then we can close it from there.
Thank you so much, Dr. Mercy. For me, I will just tackle on the issues of why did we have to change the law to this social health insurance law if it is similar to NHIF or it is a revamp of NHIF. The law under NHIF was one, very limiting in terms of the provisions. The NHIF law could not allow government to even put in funds or allocate funds for such things like primary healthcare or emergency fund. Two, the law under NHIF had not capped administrative costs like the way SHA has done, so that all the money that is collected is actually spent on paying health services, and only 5% is retained by SHA. And the law that time allowed NHIF to do accreditation and go out there and accredit facilities together with the KMPDC and all other regulators. We had to change that. So the issue is that the law had undergone a number of metamorphoses since 1998, when it was, in fact, since 1966, when it was had been established that time, and it needed a whole new architecture. And so the issue of why did we have to, it was necessary. It had reached, I think, its end, and we needed to have a new social health landscape architecture or health financing architecture for purchase of healthcare services. Thank you.
Thank you very much, Terry, for that. Dr. Mwai?
Thank you very much, colleagues, and thank you, Mercy, for the moderation. I would highlight two things. One is that the architecture that is before us as a healthcare system or people working within the healthcare system is a system that can work. But for it to work, we need to coordinate ourselves. We need to take advantage of the moment and commence our journey towards ability to have a well-financed healthcare system that ideally responds to the needs of the Kenyans in terms of healthcare needs. And the benefits continue to grow up to the time when we saturate. It can never be done in day one, but this will continue. And with the time, as corrections improve, we should be able to add more benefits. Now we are at the rollout phase, and it is important for us to highlight that it is with serious recognition that we know that national rollout is a major event. It experiences challenges, but the greatness of the moment is in the ability to address the challenges as they arise, to make changes that are necessary, and make sure that the healthcare system stands and services continue to be provided, and we are able to roll out our healthcare system new architecture. So where difficulties are found, we hope that we'll all work together to solve those difficulties, and we, work together towards making sure that both the provider side of the economy as well as the demand side of the economy, these are the suppliers of the services and those who need the services, get them without incurring unnecessary strain. Thank you.
Thank you very much, Mwai. Dr. Abdi?
Thank you very much. I think we just need to realize that out-of-pocket payment is not a sustainable way of purchasing health. We are all in agreement that you need to insure your car, but we frown on when we are told to insure for your health. Then we also need to realize that it's not sustainable to have only the elderly who face the burden of the disease mostly to be covered on their own, that scheme is not sustainable. So what we need is that the universality is what helps us reduce the burden on each individual, and also that reduces the burden on our retirees, on our parents and elderly, from facing the challenge of having to sell everything that they have worked for because they are trying to seek health using out-of-pocket means. So they end up liquidating all the assets that they have accumulated, which could have gone to their children. But it's now the children who are employed elsewhere, who are healthy as expected, but feel it's a burden to pay extra 2,000 or 3,000 because they are just imagining that it's too costly, but not knowing that it's reducing many more burdens from them and having the challenge of paying for their elderly parents or their relatives Harambe. So once we understand that bit, that we need to contribute collectively and have a basket that we use to pay for our diseases, then we will not feel the pinch. And when we also educate our patients, our relatives, our friends, that it's better we have this basket, then it's all in, it will help us get all the benefits that we are yearning for, all the extra things that we would want. So for me, I would say that let's encourage each other. Let's enroll our house helps, our garden boys, our drivers, and pay for them or tell them to pay for their insurance. That way, we will be able to overcome two challenges. One, unsustainable product with limited benefits, and move to a more sustainable product that has many more benefits for all of us. With health, you never know when you will need it. And when the time comes, that's when you realize that you are in trouble. And even those who are advocating, there's nothing wrong with having a private insurance, but just keep in mind that you will pay an arm and a leg for you to get the kind of benefits that you want, while you still be followed by limitations on age exclusion or disease exclusions. Here, we are telling you there is no exclusion, there is no age limit, and there is no waiting period for you to access benefits. That's why it's a social health insurance, and let's do this Harambe together. Thank you very much.
Thank you very much, Dr. Abdi, Chairman Shah, Terry Rotich, State Counsel at the Ministry of Health, and Dr. Daniel Moy, who is the Presidential Advisor on Health. This has been really, really engaging, informative. We still have very many questions, comments from the attendees, and I think we should probably consider having another conversation so that we are able to tackle any other emerging issues that people have, especially once, like Abdi has promised, when the system update is done and there's a rollout, I'm sure there'll be a lot of feedback coming back tomorrow as providers and as users of the system. So we hope to continue this engagement so that we can all learn. Thank you very much, colleagues, for your time, for your engagement, for your questions, for your comments. This has really been good, and I must appreciate all of you. My name is Dr. Mercy Korir. I have been your moderator for this session, and I look forward to hosting you for another one. Everyone, do have a good evening.